I'm afraid we're going back to trying to get babies off ventilators again, having had that wonderful lecture on how best to manage a baby with an endotracheal tube. I'm going to try and convince you to use something to get these babies off as soon as possible, which I think is a philosophy that's shared by Anton. And the thread of this next talk is going to be the CAP trial, a Caffeine for Apnea of Prematurity trial. Methylxanthines, why are we interested in them? Why are they important to us? Well, they're important because they're dealing with one of the most frustrating and common issues in neonatal intensive care, and that's apnea of prematurity. It's very common. It's the reason we start drugs. It's the reason sometimes that we ventilate babies. Methylxanthines, and that includes aminophylline and theophylline and caffeine, have been administered since the dawn of modern neonatology for at least 30 years. And still, caffeine is in the top 10 drugs prescribed in the intensive care unit. Now, because George isn't giving a talk, I've got to give you some philosophy today. And this comes from Archie Cochrane, who's a hero of mine, and he's the guy who started the idea or challenged us to form the Cochrane collaboration. And this is what he said: healthcare resources will always be limited. There's never going to be enough to go around. Therefore, they should be used to provide equitably or fairly those forms of healthcare which have been shown in properly designed evaluations to be effective. And there's a lot of wisdom in this sentence. We live in a finite world, and current days, Europe, whether you're in Europe or North America or Australia, there's budgets that have to be met, and we have to work out how best to spend our money. It's important that we have a conscience about this, how we spend our money. It's got to be spread so that it does the most good for the most people. And when we're talking about therapy, then the whole thrust of this conference is finding out what's the most effective therapy, so that we're not wasting our valuable resources on therapies that don't work. Here's an American philosopher: those who cannot remember the past are condemned to repeat it. And for us in neonatology, this is a very important warning, because we've made lots of mistakes and we have continued to make lots of mistakes, so we need to heed this warning. And to another of my heroes, Bill Silverman, who passed away some years ago now, but was a North American neonatologist who went through the dawn of modern neonatology, got to the end of his career and looked back on some of the therapies that had appeared throughout his life as a neonatologist. And he classified these into treatments that were effective, which I haven't included here, but some treatments... Okay. When all else fails, we can use the mouse. He classified treatments into those that led to disaster, and those that weren't disastrous, but they didn't achieve anything. They misled into fruitless byways. And so this is what I mean by making mistakes in modern neonatology, things that seemed like a really good idea at the time. Lots of people started to use them, and it took us maybe 5 years, maybe 10 years to decide that these were disastrous treatments. So diethylstilbestrol to prevent recurrent miscarriage, a great treatment for miscarriage, but then we had that epidemic of the consequences of that down the track with fetal and abnormalities in children. Supplemental oxygen, sort of the landmark in modern neonatology. A great idea. It made babies turn pink. It made them look lovely. It made their breathing more regular, but it led to this epidemic of blindness. Thank you very much, David. That's great. Chloramphenicol prophylaxis, very good to prevent neonatal infection, but the disastrous consequences of the grey baby syndrome, and so forth. So the point is that we need to be careful not to repeat these mistakes in our modern choices of therapy. So caffeine, why might caffeine be important? Well, our population, our patients, they do a lot better now than they did maybe 10 years or 20 years ago, but we still have a major burden of illness. Still, we have a long way to go. Many of our babies still die, and of the survivors, many of them emerge from our care with severe disability. So we still have a problem. We still need to be thinking about new treatments. As I said, almost all of our preterm babies at some time in their stay with us have apnea, and at some time go on to methylxanthines. So the rationale behind the CAP trial was that at the time we started, there was a lack of evidence of safety. We know that the mechanism of action of methylxanthine is to antagonise adenosine receptors. We also know that adenosine is neuroprotective during hypoxia. So this seems like a bad combination, babies who are periodically becoming hypoxic, and to give them something that lowers their defences against hypoxia. And I'm hoping Jerry will expand on this after morning tea, but there is some evidence going way back that in animal models, the combination of methylxanthines and hypoxia was a bad one. If you make rats or mice hypoxic and you give them methylxanthines, they're more likely to die. They're more likely to have decreased survival after bowel ischemia, and you can give it to rats very early on in their development, let them grow through to adulthood, and you can see permanent changes in the development of those adenosine receptors right into adulthood. So there were some worrying things that most of us clinicians, because we didn't read that literature, should have worried us about methylxanthines. And combined with that sort of worrying animal evidence, there was very little in the way of human evidence to test this commonly prescribed treatment. The Cochrane review at this stage, it said a very lukewarm response to methylxanthines. Maybe it will help get you off the ventilator, but the results of the meta-analysis that we did at that time did not allow firm recommendations to be made for clinical practice. There was a suggestion that caffeine was probably the drug that should be chosen because it's a safer drug. It's got a wider therapeutic margin and should be tested against placebo. And there was this suggestion by the Cochrane authors that, well, not only should we be looking at its effect in the nursery, does it get babies off ventilators, but really the major question was how does it affect babies in the longer term? So this was the aim of the CAP trial, looking at very low birth weight babies at risk of apnea of prematurity. Does the use of caffeine compared with placebo increase the risk of death or neurodisability? So a fairly simple question, and dealing with important outcomes, not just getting babies off ventilators, but looking at their long-term outcome, in this case 18 months. So we've heard a lot and from myself and other speakers about different studies, different types of studies. I would argue that for an important question about therapy, we need a randomised trial to guide us for the reasons that Bill Silverman suggested. If we rely on other forms of evidence, we're likely to get it wrong. So this was a randomised trial. It was multi-centred, based in Canada and Australia and extending through the UK and parts of Europe, placebo controlled and double-blinded, so nobody knew what they were getting. Much easier to do a drug trial than a ventilator trial in this way, and you can be much more confident of the results in this case where the doctors don't know what the baby's getting. The entry criteria, these were our common babies in intensive care, babies between 500 and 1250 grams, enrolled in the first 10 days of life, and a very pragmatic inclusion criteria. To be included, your clinician just had to say, well, this is a baby I'd normally use methylxanthines in. Exclusion criteria, so dysmorphic babies with chromosomal abnormalities, for example, were excluded. If we didn't think we could follow babies up to 18 months, they were excluded. This was a very rare reason to exclude babies, and if they'd had some prior exposure to methylxanthines. So getting back to the primary outcome, it had to be something important, so death, very important, or survival with one of 4 neurodevelopmental problems, so cerebral palsy, a mental developmental index equivalent to an IQ less than 85, so more than a standard deviation below the mean on a Bailey score, severe hearing loss, or bilateral blindness. So that was the composite outcome that we thought was most important for these babies, their families. We heard from Anton the problems and the suspicions that arise when sample sizes of 20 or 30 or even 100 are used. And I think there's very few treatments in neonatology that convince clinicians with less than 1,000 babies enrolled in trials. And the reason for this is that you need, and for this trial, for the CAP trial, the maths is fairly simple. We needed 2,000 babies to reduce the bad outcome from 30% by 25%. So quite a substantial reduction in the primary outcome, but to do that reliably, achieve conventional power and alpha values, 2,000 babies. And that's a lot of babies. That means a lot of hard work. The intervention. Sometimes the details are very important. So babies were either randomised to caffeine or placebo. The loading dose, 20 milligrams per kilo of caffeine citrate. So just be careful, we're talking about caffeine citrate, not caffeine base. And then a maintenance dose of 5 to 10 milligrams every day. So people would start at 5 milligrams per kilo. If that wasn't working, if the baby was still symptomatic, they could go as high as 10 milligrams per kilo. No levels were done for the obvious reason that would unblind the study. I point this out because since the results of the CAP trial came out, there's been an enthusiasm to say, well, if 20 milligrams per kilo is good, well, maybe 40 milligrams per kilo will be better, and maybe we should be going to a maintenance dose of 20 milligrams per kilo. But the evidence is based on these doses, and these doses, I think, are the ones to stick to. This is the flow chart. So as usual, we start off with many more babies than we finally enrol. For various reasons, eligibility, consent refusal by parents, but we got to our sample size of just over 2,000. The follow-up rates, very good. We like to see more than 90% in any of our randomised trials. This was up into the mid-90s, which I think is probably easier to do in countries like Australia and Canada than perhaps in the US. Just to describe the patients, they're predominantly white mothers. About half of them have got a college or university education. Rate of single mothers quite low. Rate of employed parents quite high. So perhaps we're getting a picture of a well-off population of families enrolled in this study. We're looking at babies on average around a kilo, on average around 27 weeks, 50-50 split, boys and girls, very high rate of antenatal steroids, and a fairly high rate of multiple pregnancy that we would expect in this population, and no difference between the two groups with respect to those infant characteristics. This is what happened in the trial. We didn't give any guidance to clinicians. They would stop the drug when they felt the baby no longer needed it, and I guess this mirrors our common practice, stopping the drug at around 34 to 35 weeks. Placebo baby stopped maybe a few days later, but that's of marginal significance. This was a blinded study. People were asked to record whether they thought the baby was caffeine toxic, so tachycardia, for example. The rates of perceived toxicity were very small in both groups, and no statistical significant difference between the two groups. the use of drugs outside the trial, so open label, where people felt they just couldn't withhold caffeine any longer from their baby. It was unethical not to give a baby caffeine, was very similar in both groups, slightly higher in the placebo, but not statistically significant. And about 10% of babies in each group got one or more doses of methylxanthines outside the trial. So this brings us to the results, and having said that the important outcomes are the long-term outcomes, there are some interesting and I think clinically relevant outcomes in hospital as well. So babies in the caffeine group came off a ventilator a week earlier, 29 weeks on average versus 30 weeks in the placebo group. Came off positive pressure ventilation, so includes CPAP, a week earlier, and come off supplemental oxygen a little bit more than a week earlier. So modest differences, but if you were a hospital administrator, you would say, this is great, this is great, this is going to reduce our costs, because having a baby on a ventilator is an expensive business. If we can reduce that time by a week, that's good news. Other neonatal outcomes, bronchopulmonary dysplasia reduced by 11% from 47 to 36%. That's a statistically significant result. Risk of patent ductus arteriosus also decreased, and the need for surgery for a patent ductus arteriosus also reduced significantly. And the reasons for that maybe scientific, maybe physiological, the diuretic effect of caffeine, or maybe just getting the baby off a ventilator earlier and people being less concerned about the presence of a murmur. But the main outcome, the primary outcome, death or disability, there was a significant reduction from 46% in the placebo group down to 40% in the caffeine group, and that's highly statistically significant. The odds ratio does not cross 1. 16 babies treated to prevent one death or case of disability. So again, it's a bit like the cooling story. Yes, this is great that we've made an important reduction in a very bad outcome, but we've still got a long way to go. 40% of our babies still have a major problem. There are no magic bullets, or it appears there are no magic bullets in neonatology. So if we break down the primary outcome into death and disability, so looking at death, no effect on death. The rates of mortality in both groups are almost identical. The difference is therefore in the rates of disability, so cerebral palsy reduced, cognitive delay, so a low IQ or a low MDI reduced, statistically significant. Rates of deafness and blindness are actually quite low in both groups. There's a trend favouring the caffeine group, but that's not statistically significant. But important differences in rates of cerebral palsy and cognitive delay. People were worried that caffeine would stunt the growth of these babies, but there was no evidence of that, either in terms of height, weight, or head circumference. And the conclusion at the end of this trial, caffeine improves survival without neurodevelopmental disability in very low birth weight infants when we looked at 18 to 21 months. So there's not a lot of treatments in modern neonatology that you can say that about. All good trials raise more questions than they answer. A little post-hockery. So why does a respiratory drug, why does a drug that works on the respiratory centre improve neurodevelopmental outcomes? And we undertook a fairly sophisticated analysis, stepwise logistic function analysis on the likely variables that might explain that. And the things that we put into that model were the postmenstrual age at last endotracheal tube, last positive pressure, last supplemental oxygen, the use of postnatal steroids, surgery for PDA, and the rate of BPD, all of which have been associated with long-term neurodevelopmental problems. if you put all the variables into the equation, that explains about 55% of caffeine's effect on the primary outcome. So that's good. We've got a little bit of over halfway there. The most important variable when we ranked those variables was the earlier discontinuation of positive airways pressure. So getting back to what Anton said, to get a baby off a ventilator makes sense in the short term. It also makes sense in the long term. But it leaves 45% of the effect unexplained, and this is interesting and needs further work. Okay, so now George gives me a topic, and I sort of talk around the topic. But this was the assigned topic. What about within subgroups within the babies enrolled in the CAP trial? The CAP trial, as I said, occurred on the basis of a limited amount of previous evidence. But the previous trials and the systematic reviews had looked at methylxanthines in very isolated ways. It was either used as treatment for apnea, apnea prophylaxis, or apnea before removing an endotracheal tube. The CAP trial, big trial, the inclusion criteria was just that the clinician thought the baby might benefit from methylxanthine therapy. So all of these babies were lumped together within the CAP trial. And the results are as I've showed you. So I guess, like many trials, this comes about sitting around with your colleagues in the pub after the trial has been presented and thinking what's going to happen next, and people throwing up ideas and disagreeing with each other and saying, well, I think caffeine's only going to work in this group, or caffeine's more likely to work better in this other group. So what we set out in this series of post hoc examinations of the data was to see whether the size of the caffeine treatment effect was the same or was consistent over clinically important subgroups identified at the time of randomisation. So we went back to those original trials, apnea treatment, apnea prophylaxis, pre-extubation. Did the indication for caffeine have anything to do with the success of that drug? There's also disagreement. Is caffeine going to have a benefit if you're off a ventilator completely, or is it only going to have an effect if you're on a ventilator? And then the question was, well, should we be starting caffeine really early, or should we wait until the baby is later in the course? Having said that, for me, the randomised trial is the important way of arriving at conclusions. It's important to admit here this is a post hoc analysis. The outcomes that we looked at were those showing treatment effects in the original analysis. So this wasn't something we thought of before we started the study. This is something that happened afterwards, and therefore should be regarded as weaker evidence. A little bit of the statistics. We're going to talk about odds ratios and mean differences and 95% confidence intervals. And what we're going to be looking for is evidence of heterogeneity or inconsistency between inconsistency of the effect across the different subgroups using logistic or multiple linear regression models and incorporating treatment and subgroup factor interaction. Lots of words. It becomes a lot easier when we look at some graphs. For all of these analyses, we adjusted for things that we knew would make a difference to the long-term outcome, like gender, like maternal education, like the rate of antenatal steroids and multiple births. When we're looking for evidence of interaction, we're looking for a p-value less than 0.05, and that would be considered to represent evidence of a subgroup effect. Okay, that's lots of words. This is what it looks like. So this first graph looks at the primary outcome, death or major disability, and the subgroups we're looking at are the main indication for starting the drug. So this was written down in the case record form as the clinicians enrolled the baby. So they had to say what the baby was started on the trial medication for. So it could either be apnea treatment, apnea prophylaxis, or started pre-extubation. You can see that there are reasonable numbers in each group, 700, 400 and 700, 600 or 700 again. So within each subgroup there is reasonable numbers of babies. And you can see that, yes, the bottom line when we put all the data together is caffeine works, and that's good. You can see there is a little bit of difference between each of the three groups, and perhaps less evidence that apnea prophylaxis is useful. It's right on the line of unity, so no effect. But if you look and apply a very tough statistical test, there is no evidence for heterogeneity. The p-value is 0.44, a long way from 0.05. So no evidence that the reason for starting the medication had anything to do, any effect on the primary outcome. And the same was you could say for the short-term outcome of the need for oxygen, the postmenstrual age at last oxygen treatment. Again, some slight variability, and again the apnea prophylaxis group seeming to show less benefit than the other two groups where you're actually treating something or giving it pre-extubation, but again no evidence of interaction. And we, without boring you with a lot of graphs, we looked at the other important outcomes: cognitive delays, cerebral palsy, BPD, BDA, last time on a ventilator, last time on an endotracheal tube, no effect there. So indication for starting seemed to have no effect. However, when we looked at the level of respiratory support at randomisation, and again looking at the primary outcome, death or major disability, dividing the groups up into no respiratory support, non-invasive support, so predominantly CPAP or an endotracheal tube, we start to see some differences appearing. So babies who were not on any respiratory support, actually a trend towards harm, a trend favouring the placebo group. The other two groups, particularly babies on an endotracheal tube, strongly to the left of the line of unity, does not cross one. The babies on CPAP just crosses one, but again a strong trend favouring the caffeine group. And looking at the test for heterogeneity, both the unadjusted and the adjusted p-values well below 0.05. Okay, so some evidence that there is some variability in the groups with respect to the amount of respiratory support that they're having before starting the study drug. To me, this means caffeine, the idea that caffeine should be started on all babies, irrespective of their need for it, might be a little bit flawed. And I think it seems to me that the more you stand to benefit from caffeine, the more likely you are to get an important neurological advantage from it. So to give it to a baby who's not needing any respiratory support, perhaps less likely to do good than if you're trying to get a baby off a ventilator, for instance. Another statistically significant result, if we look at cognitive delay, and again the babies on no respiratory support seem to be different to those who are either on CPAP or an endotracheal tube, and a highly significant p-value. No other significant differences between any of the other groups, any of the other outcomes. And then the question of starting, the age of starting. On average, babies started at 3 days, so we split them into the early group starting before 3 days and the late group starting beyond 3 days. Both groups showing a benefit, but it looks like starting early gives a greater benefit, a significant p-value. And we're talking about the outcome of last endotracheal intubation here. Last positive pressure ventilation, similar. No other significant differences with respect to the timing of starting the study drug. So the conclusions from this little side study was that there is evidence of variable beneficial effects of caffeine. If you're on respiratory support, whether that be CPAP or an endotracheal tube, it seems you get more benefit from caffeine than babies who are not requiring any support. And babies started on caffeine earlier had a greater reduction in time on ventilation, perhaps a less important outcome. Okay, so we need to update this information with the most recent follow-up of the caffeine, the CAP trial, and we're now up to 5 years. This was published last year. The older babies get, the more sophisticated can be our look at their growth and development. And so for the 5-year outcome, we defined the primary outcome as death or survival with disability in one or more of 6 domains. So not only the motor function and cognition that we were able to look at 18 months, but now we're able to look at behaviour and general health, and still looking at hearing and vision. Motor function, we're now able to apply more detailed motor analysis. So we're using a gross motor function level greater than 2 as the criteria for disability. The WIPSI-3, the IQ test of less than 70, so that's severe cognitive delay. Child behaviour checklist is the measure of behaviour, and the definition of disability was a score more than 69. General medical or general health, babies, again, this is the severe end of the spectrum, babies who are still at 5 needing oxygen or positive pressure, having frequent seizures, intravenous or tube feeding or intensive care admissions, and deafness and blindness down the bottom. So you can still see we're looking for quite serious disabilities here. The follow-up rates, of course, drop a little as the babies become older. There were some centres that were unable to follow any of their babies, and amongst the centres that could, some babies are lost because of families moving, etc. But we're still up into the mid-80s for follow-up rates, which is, I think most people consider pretty reasonable. This is the characteristics of the 5-year cohort. Very little difference between these and the original figures that I showed you. Babies up slightly under a kilo, 27 weeks, female, male, roughly the same, steroids and multiple pregnancies, the same as we've discussed earlier. Slightly smaller group, but the demographics are still very similar. The mothers and the families, again, very little different to the figures I showed you earlier. The outcomes at 18 months of this particular cohort, no different to the original cohort. So in spite of losing a few babies, the results at 18 months were the same. But moving to their 5-year outcome, we find that the gap narrows between the two groups. So in the placebo group, a rate of death or disability just less than 25%, down to 21% in the caffeine group. Odds ratio 0.82, confidence interval just slips above 1, and a p-value that's no longer statistically significant. And looking at the individual components of that primary outcome, no significant differences in any of the scores, whether that's motor, cognitive, behaviour, poor health, deafness and blindness. You'll see some trends favouring caffeine in all of the outcomes, but none of them statistically significant. The one thing that did remain statistically significant was a test of gross motor function, a highly significant difference between the two groups in terms of numbers who emerged without any problems in that gross motor area. So although the observed rates of functional outcomes still favoured caffeine therapy over the placebo group, these were not statistically significant. The one thing that was the gross motor impairment, less severe in caffeine compared to the controls. Interestingly, the rates of cognitive impairment decreased over time. So between 18 months to 5 years, these babies seem to be getting better. We can discuss that, and I'd be very interested in Jerry's thought. I think the conventional wisdom that this tells us what we suspected, that babies have plasticity of their brains and they're able to repair damage better than perhaps older people. So the positive result of cognitive impairment that we saw at 18 months no longer seen at 5 years. Okay, so overall, we'll wrap it up. Caffeine has important short-term benefits. These are important for the babies. These are important economically, getting babies off ventilators, reducing BPD, etc. Reduces a neurodevelopmental impairment at 18 months, but the magnitude of its effect reduce at 5 years. And there is some interesting things emerging from that sub-analysis that I showed you, and it seems as though babies on respiratory support get more neurodevelopmental benefits from caffeine compared to unsupported infants. So I'm going to stop there, but as George said, it's a time for thanks. So thank you, Blueberry, up in the back row, for looking after us so well. Thank you to Janice for being such a wonderful host, to George for thinking of me and inviting me. It's been a wonderful privilege to be part of this. Thank you for your questions, both from the floor and the really tough questions that come when you're having a cup of coffee, the ones that people are afraid to ask in the room. So I encourage the shy women, it usually is, who come up to you in the breaks to ask your very good questions in the hall. So I'll stop there. Thank you very much for your attention, and any questions, I'm happy to answer them.
The question I had is whether, or it occurred to me that some of the, you called it plasticity, that the infants were getting better, might also be related to the different metrics you used at 18 months and 5 years, and maybe, I'm not familiar with these kind of follow-up metrics, so I'm not sure. What do you think?
Absolutely, that's a big possibility, Tom, that the tests are different for obvious reasons. Your ability to test an 18 months cognitive ability is much different to a 5-year-old. These tests are standardised on population norms, but the point is well made. These are different tests. I don't know if Jerry wants to make a comment about sorry, you're thinking of other things, but the reliability or the predictive value of 18-month tests for longer term tests of cognitive ability, so comparing the Bailey with the WIPSI. Any thoughts?
In terms of types of testing we do, I think it's difficult to compare them for, like you say, for obvious reasons. We are rather hesitant to sort of make a diagnosis often of cerebral palsy before the age of 2 for the very reasons that Peter has pointed out, and that is children can both grow out of their disability to some extent, and they can also certainly grow into their disability. And so prior to 2, and we're certainly now finding that even as they go on, you can get increasing evidence of some degree of disability, although minor. There's been some work by Miller and even in a little bit of our work, we found that at least in kids with like congenital heart disease, etc., if you look at their MRs are actually quite similar to kids who have kids who are premature. In other words, their brains almost seem to be immature for the age that they are, and I wonder if sort of a similar kind of thing is going on in some of the premature babies and with the use of caffeine, and for some reason they're able to pick up as they get a little bit older. I'll talk a little bit very briefly when I give my talk about caffeine in normal brains, but we're finding sort of something like that, I think.
Another interesting thing, I find it interesting anyway, is it seems that some babies catch up more between 18 months and 5 than others, and the babies who catch up more are those in the best environments. It's a very strong correlation between maternal and paternal education, employment status, and the rate of rise of IQ over that time. So the babies in a good environment have much better catch up. The babies coming from poor socioeconomic single parents, unemployed mothers, some improvement, but much less than the babies raised in a strong environment.
Were you able to find that in your study, or did you look at that?
Yes, yeah, that's from our work. It's in the hands of the journals as we speak. Yeah. Looks like everybody wants to get their caffeine.
Not the caffeine, the evaluation.
Oh, there. Yeah, sorry.
The last one before the break. What about the predominant hypoxic premi with intra-uterine growth restriction and the long-term outcomes on the neurodevelopment impaired according to the caffeine supplementation?
So let me make sure I've got your question right. Is there a
because you said in your lecture that the outcomes could be different in this group with hypoxia and correlated in predominant hypoxia, like we have in intrauterine growth restriction. How does it correlate during the treatment that group of patients?
That'll teach me for asking the smart young women to ask questions in the forum, because that's a very good question. I don't know the answer to that. We haven't looked at a subgroup of growth restricted babies or babies who'd had a lot of hypoxia beforehand. I guess the animal evidence is that it's got to be concurrent, so it's not really what happened to you as a fetus, being IUGR, and then adding caffeine on top of that. But that's I'm just guessing.
Thank you very much. Indeed, the goal was: did we harm them? They more? Help them?
That's entirely possible, but we haven't looked at that group.
Thank you.
Yeah.
Thank you for your excellent lecture. I have two questions. First is about monitoring of the caffeine therapy.
Yes.
Do you make this procedure in your department? And second question is about effects of methyloxanthines on kidney function in the patient after asphyxia. Can you comment this?
Okay, so the first question is easy. Do we monitor caffeine levels? We introduced caffeine through the CAP trial. Before that, we were using theophylline and aminophylline and measuring the levels religiously as you had to do. We got used in the CAP trial to not being able to measure levels in any of our babies, and so when we started using caffeine, we've continued to just monitor them clinically. So if the baby's tachycardic, we'll drop the dose. If the baby's apneic, we'll increase the dose. So we just go clinically for these babies, and we don't do serum caffeine levels. Sorry, repeat the second question.
Second question is about nephroprotective effects of methyloxanthines.
Nephroprotective. I'm not aware of nephroprotective effects. I know that one of the results in hospital outcomes was some weight loss in the first week of life, a difference in weight loss between the caffeine group and the placebo group, which I think is probably the diuretic effect of caffeine, particularly strongly in that first week. But whether that's and that difference disappears over time. So I think there's an acute diuretic effect, but nephroprotection, I'm not sure.
1 year ago, in the Journal of Perinatology, was published an article, meta-analysis of 2 randomized trials about effects of theophylline for reduction of kidney failure in the patient after asphyxia.
Right. Yeah, and it showed it was good?
Yes, we have good effect. Of course, they don't recommend this treatment because this population was too small, but they observe some good effect after prophylactic treatment of methyloxanthines.
Yeah. I don't know. I guess I'd be interested in the other neonatologist's view, but my view of renal failure post-asphyxia is that you leave them alone and you pay careful attention to their fluid and electrolyte balance, and they get better with time. And attempts to make their kidneys better with drugs, we previously have used diuretics, but probably caffeine as well. May speed things up, but doesn't make any difference in the long term. But I'd be interested to read a little bit more, but I have no experience.
Thank you.
Are there any more questions? If there are no more questions, I kindly ask you to take your time now, fill out the evaluation form, and she and I will collect them at the door. So if you don't want your bladder to rupture, like famous Tycho de Brahe, who was invited to the king's meal, and he drank too much beer before, but he could not leave before the king had left, so he had a bladder rupture. So fill the forms out, give them to her or to me, and then you can go to coffee or toilet, whatever you like.